I'm Dr. Carl Michel, practicing board-certified foot and ankle surgeon and proud member of T. Lee Ward Jefferson Medical Society here in Palm Beach County. Our organization takes pride in leading the way in subject matters that affects our community, one of them being the opioid epidemic. Our goal in this fourth series is to continue to draw awareness, educate our community, and help in the prevention of opioid dependency and death.
Sandy Collier, and thank you for joining us. On this episode, we're going to talk to medical students about what they're learning in terms of opioids. And we're also going to talk to a pharmacist about how pharmacy education has changed over the last 15 years. I'm Sandy Collier, and joining me on this episode is Dr. Jermaine Smith. Dr. Smith, thank you so much for being here.
Oh, thank you for having me.
Now, you are a pharmacist.
Yes, I am a Florida licensed pharmacist.
So tell me about yourself and your education. Let's talk a little bit about you.
Sure. So my career started in 2008 where I graduated from Florida Agricultural and Mechanical University. There I got my doctorate of pharmacy. After graduation, I started my career as a retail pharmacist. After that, I matriculated into being a pharmacy manager for a retail setting. And currently, right now, I am a pharmacy clinical service manager, a regional pharmacy clinical service manager. Basically, my job right now is educating pharmacists, and I support about 170 pharmacies and making sure they understand exactly what they need to do clinically and have that right education. Specifically, one of my responsibilities does relate to the opioid crisis and making sure pharmacists understand how to manage opioids and how to dispense it.
Doctor, you've been in medical school. We've been talking 15 years ago.
2008, yeah.
How has pharmacy school changed in terms of education versus today?
I would say as far as the education, it's pretty much the same, but there is definitely more of an emphasis on opioids because of the opioid crisis. When I graduated in 2008, the curriculum was pretty much the same, but we didn't have emphasis on opioids. It was treated just as any other area. For example, same as blood pressure, diabetes, there was no specific emphasis on opioids. But today there is now. I remember reading something, and I read that in 1999 to 2014, there was a great increase in prescriptions of opioid prescriptions, about quadrupled, compared to the amount of diagnosis of opioids. So we could see the disparity of exactly what's going on and why there's such a need of a focus on the opioid education because of the crisis.
So, doctor, what is diagnosis of opioids? That's the first time I've heard that.
Okay, so it's just the amount of patients that cite that they're having pain to their doctor, and the doctor actually writes down and records that they have a diagnosis of some type of disease state or disorder that's causing the pain. So we're talking about cancer, back pain, the recording of exactly that diagnosis of having pain.
What do you believe the role of the pharmacist should be in terms of this opioid crisis?
Yeah, so the primary responsibility of the pharmacist is to verify if that prescription is valid. And that's for any prescription, but specifically for opioid prescription, there needs to be some type of urgency around that. So one of the things that a pharmacist could do is they need to clear the red flags of prescriptions. And there's three types of red flags. We have prescriber red flags, we have patient red flags, and then there's also prescription red flags. So examples of prescriber red flags would be, is that prescriber prescribing the prescription based on their practice? So for example, if you have an ear, nose, throat doctor, ENT, are they prescribing pain medicine for a back pain or cancer pain? Then that's something that's a red flag that's unusual. Also, as a prescriber red flag may be, is that prescriber writing prescriptions for a high number of tablets on a prescription, or is their dosing that they're prescribing, is it unusual and very high for what they're treating of that disease state? If we talk about a little bit about the patient red flags, some of the red flags could be, is the patient picking up the prescription in their known geographic area? So for example, we're in Palm Beach. If we have a prescription from a doctor written in Palm Beach, but the patient lives in Orlando but goes to a pharmacy in Miami, that's a red flag. What's going on? Not to say that that's unusual or can't be something that happens. Maybe the person is a transient worker, maybe they're a trucker or something to that, but that's a red flag. It needs to be cleared to make sure that prescription is valid. Another patient prescription would be, patient red flag could be, is whether that patient is doctor shopping or pharmacy shopping. So do we realize that this patient has multiple doctors treating the same disease state? Or is this patient going to different pharmacies picking up similar or the same medication? So those are red flags that pharmacists need to clarify and to make sure that they're valid. And the third one is prescription red flags. So is the prescription, does it look valid? Does it sound, appropriate for the diagnosis? Is the prescription written in different colors, the different handwriting? Is the prescription actually from a valid prescriber? And that's something that needs to be clarified. So we talked about the red flags and making sure that the prescription is valid. So that's the first priority of a pharmacist.
Let's talk about the prescription a little bit again. How do you know that a prescription is not valid? Let's say a patient has a doctor prescription, stole it off the doctor's desk, writes a prescription for themselves. How do you know that that prescription is not valid?
So it goes part of your training and your experience. And this is something that's happening very fast. The pharmacist is dealing with other patients, other prescriptions, doing immunization. So it's something from training that their eye, something that they could catch with their eye from training. Now, you're not going to do this for every single prescription, but right away you could tell when something doesn't look right. Why is this prescription name spelled incorrectly? Why does the prescription have the street name and not the regular name? What about the number of tablets and how it's written, how many times the patient should be taking it? If it's very unusual, it catches your eye very quick, and that's part of the training that pharmacists learn in school.
Wow. Talking about what you've learned in school, how has opioids changed over the last 15 years since you were in pharmacy school?
Oh, yeah. So as I mentioned before, opioids, there was a category going over opioids in school, but right now it's a heightened sense of urgency because of the crisis. And as I mentioned before, that prescriptions for opioids over that time period of 1999 to 2014 have quadrupled. So it's definitely an emphasis on what's going on, with the crisis and making sure that we do our part as pharmacy to alleviate some of the overdoses and the opioid crisis.
Tell me about your experience with a patient who may have, patient walks into the pharmacy, you and I were talking about this, that you can see that patient probably does not need to be on opioids. Tell me about one of your experiences.
Wow, so you'll have several experiences like that as a pharmacist. And it is your duty and your job to make sure you take that patient's safety into concern. So I could remember a specific incident when a patient came in and they're looking lethargic, they're looking sleepy, they're having slurred speech, and they're picking up a high dose of opioid prescription. And then sometimes you could smell some type of substance, either alcohol or marijuana or some other type of substance on them. So you have to decide in your mind, is it best for this patient to take this prescription that you're giving them. We do have ways as pharmacists to kind of look up. We have a database in Florida that was created a few years ago where we could look and we could see if, let's take a look and see who's prescribing this patient medication. Are they going to different pharmacies? So I could see literally if you came to my pharmacy today, I can tell if you went to a different pharmacy yesterday and picked up the same prescription. So that's some of the tools that we have. But at that point, it is up to the pharmacist to respectfully reject the prescription. And at the end of the day, the pharmacist is the one to decide if they're going to give that prescription to that patient. They are the front line between that prescription and that patient getting that medication.
Dr. Smith, we talked about pharmacy responsibility, but I gather there are more responsibilities. What are some of those other responsibilities?
Oh, definitely. So we talked about clearing red flags and verifying the validity of a prescription. So besides verifying the validity of the prescription, the pharmacist's responsibility is also to verify the appropriateness of that prescription. Just because the prescription is written by a valid prescriber and there is a patient-prescriber relationship doesn't mean that that prescription necessarily is accurate or clinically appropriate for that patient. For example, you shouldn't see a patient with a tooth abscess getting the same amount of prescription for a patient that's suffering from cancer. Those two shouldn't be the same. One of the tools that pharmacists use is, and it was created by the CDC, is we kind of look at morphine milligram equivalents, the MME. So it is known that a prescription that is over 50 morphine milliequivalents could cause a little bit more side effects and could cause a patient to be a little bit prone to having major side effects such as overdose. So initially, if a patient is opioid naive meaning that a patient has never received the opioid prescription before, we try to minimize, or a prescriber should minimize, that prescription to 3 days and under 50 morphine milligram milliequivalents, 50 MME. So with that said, so acute disease such as a tooth abscess should be about 3 days worth of supply and should be under 50 MME. If the patient needs a little bit more, then it should be about a 7-day supply and should still be under 50 MMEs. And if the patient is chronic, then we consider that non-chronic or non-acute pain. And that patient, there's really no guideline, but you still want to kind of monitor it and keep that patient near 50 morphine milliequivalents as possible, and really take heed if you're going to exceed 90, because that's really where the side effects happen. There was a study by the VHA, the Veterans Association, that saw, and they looked at all of the veterans that were on opioids. And what they found out was that the veterans that had overdosed and had deaths because of overdose from taking opioids, their prescriptions was above 98, on an average, 98 morphine milligram equivalents, compared to those that didn't, had an average of 48. So that's kind of the guideline. So that's the pharmacist's responsibility, to really determine if that prescription is accurate for what type of pain that patient is having.
So if you find a prescription being written by a doctor that you think is excessive,
yes,
I would imagine that conversation doesn't go well, right?
It depends. We have some great prescribers out there, and they understand, the opioid crisis and what's going on. But that is a conversation you need to have, and it's a conversation that you could have that could be, it's the way you approach it. I remember specifically, I had a patient who's been on this high-dose opioid for years, and this opioid treated their symptoms. And I reached out to the prescriber and I said, hey, I've been treating this patient for years now, and the prescription has been the same every time. The patient doesn't pick up early. The patient is compliant. They take it exactly how they're supposed to. And I had a conversation with the prescriber and I said, hey, have you ever thought of possibly lowering the dose of that prescription and see if the lower dose still manages their pain? And the prescriber said, you know what, I never thought about that. And that's part of the responsibility of the pharmacist. And that's some of the tough, I like to call them tough conversations that we have to have just to make sure we protect, our patients. So at a lower dose, we are able to have that patient less susceptible to having an overdose.
Wonderful. What else can the pharmacist do to make sure that they minimize the risk of opioid addiction?
Oh, definitely. Yeah. So we talked a little bit about making sure they have a valid prescription. And then we talk about, making sure that prescription is appropriate. And the third, and probably one of the most important things that a pharmacist can do, is just educate the community. When the patient picks up a prescription, explain to them that this prescription could be habit forming, and take at least amount of medication possible to support your pain. Just because a prescription says take it 4 times a day or take it 6 times a day doesn't mean you have to take it 4 times a day or 6 times a day. If your pain is managed by taking it twice a day, you want to inform your patient, take the prescription, see how you feel with your pain, and take it as least amount of times as possible. The responsibility of the pharmacist is not only protecting that patient that they're giving that prescription to, but you don't know who else is in the household. If that patient has children, so we got to tell them safe ways to where to keep their prescription and where to hold it, out of the way of children. One of the things that we do on the retail level is we actually give them a little powder that they could use to destroy their prescriptions if they don't need it anymore. So that's part of the consultation. You could tell the patient, hey, if you're not having any pain anymore, you don't want this prescription in your household, just in case to have any accidents, use this to go ahead and destroy that medication, and you could safely discard it. So that's one of the main responsibilities. Is just educating our community and letting them know the effects of opioids.
What does the powder do? I've never heard of that before.
Yeah, so
I'm learning so much new stuff from you.
Yeah, so it's a powder. So pretty much you take your bottle, you pour the powder in there, you pour a little water in there, you shake it up, and it dissolves the tablets. And then from there you could put it down, you could discard it. So it destroys your tablets for you. So when you hand off a prescription to a patient with an opioid, the expectation is that you give them a way to discard it, and then you also give them a pamphlet explaining the risk of taking that medication, especially if you're taking other medications that, they need to be careful about that.
Now, I'm going to go back to one thing here just because, we have medical professionals that are listening to this, but we also have community members that may be listening to this as well. You said that you don't necessarily have to take all of your prescription, but we need to clarify that you're only talking about opioids. You're not talking about antibiotics.
No. If it's antibiotics, you need to take all your antibiotics. If it's high blood pressure medication, high cholesterol medication, you definitely have to take it as prescribed. But we're talking about just opioid prescriptions where we're treating just pain. So you only want to take it when you have pain. And opioids work within 15 to 20 minutes. So there's no need to take it to kind of prevent pain. Because when you do that, you lead to possible dependence on that medication. And when we talk about dependence, we just talk about I'm referring to you're taking that medication just to feel normal. You're no longer in pain, but you have to take that medication to feel normal. So that's a little bit what dependency is on the prescription.
If a patient comes to you to fill a prescription and they feel like they're becoming, what are some of the signs talking about feeling normal with the prescription, what are some of the other signs that would show that they're addicted?
Well, addiction is hard to self-evaluate and to understand. But I would say one of the signs I kind of mentioned to the patients, if you don't take your pill, do you feel normal? Not if you don't take it, are you still in pain? Because a lot of the time you get to the point where you're taking the prescription and you're not in pain anymore. You're taking it because you want to feel normal. Some of the signs are feeling a little sluggish, a little tired, lethargic, just not there. Your mind's not clicking on all cylinders. Those some of the side effects of you can tell that you're a little bit dependent on the prescription.
Dr. Smith, this has been an interesting conversation. We have a lot of medical doctors, and we have pharmacists, and we have pharmacy students that are probably listening right now. Yes. What is your advice to them?
Okay. My advice to the healthcare field, I would say, is just work together as a team. It's going to take a whole collaborative team effort to get this epidemic under control, this opioid crisis under control. So when a pharmacist calls, the medical doctor, it's not because they want to. It's because it's out of the safety of the patient, and they're just trying to clear some red flags. And then also, prescribers, lean on your pharmacist a little bit. Ask for advice. Don't be afraid to get another opinion when treating a patient with opioids.
Dr. Smith, how can prescribers and pharmacists work closer together?
So the pharmacist understands, how busy prescribers are, especially, we definitely saw a pinch in the COVID crisis. So we know that they're pressed for time. So some of the things that prescribers can do to kind of help out the pharmacists when they write opioid prescriptions is write a diagnosis on there. Let us know what you're treating so we could clear some of those red flags. And actually let us know too if you're treating acute pain, if you're treating acute pain exceptions, which is that 7-day that I was speaking of. And also let us know if you're treating non-acute pain, which is chronic pain. And then that way we can know that there is a valid prescriber-patient relationship, and we can move on and make sure that that prescription gets to the patient in a timely fashion.
Wonderful. Dr. Smith, thank you so much for being here. I've learned a lot in this 20, 30 minutes that we've been chatting. I've learned a lot. Thank you so much for what you're doing for the community.
Thank you. Thank you for having me.
I'm Sandy Collier. We'll see you again next time. Well, thank you for joining us again. I am here with newly graduated Dr. Emmanuel McNeely. Doctor, thank you so much, and congratulations are in order.
Thank you very much for having me.
So tell everybody, what school did you go to? What did you do? What are you? Let's talk about that.
Excellent. So I'm very happy to be here. My name is Emmanuel McNeely, and I graduated from FAU Schmidt College of Medicine in Boca Raton, Florida. Now excited to start an exciting training career in orthopedic surgery.
Orthopedic surgery. Why orthopedic surgery?
Orthopedic surgery is a great field. I initially became interested when I was working in the gross anatomy lab, and then I conducted research with a top orthopedic surgeon in South Florida, and from there my love grew, and now I'm excited to help reduce pain and really help our patients get back to moving.
Tell me about your experience as a medical student in orthopedics.
Yeah, so my first 2 years was just like any other medical student. You get the fundamentals of knowledge and going into the basic sciences. After that, I did 2 years of research actually in the Northeast doing spine surgery research. So that was very, very impactful. And now I am excited to be completing the last 2 years and now graduated, so it's exciting.
Why orthopedic surgery?
Yes, so my first exposure to orthopedics was in research. I was a TA in the gross anatomy lab, and I started researching with a very high volume orthopedic surgeon. I loved how patients came in with pain, and 6 weeks after surgery, they were feeling better. They were going back to their normal life. So I fell in love with it, and I've been following orthopedics ever since.
As a medical student in orthopedics, what has been taught to you in terms of the importance of opioids?
First, my foundation was our medical school. It was very impactful. We had speakers actually come in, pain specialists come in and tell us the importance of making sure you get a good pain regimen for patients. And then our medical school brought in patients who were actually stuck in the pain medication addiction phase, and they talked about their experiences and how they started. So that was very impactful. And then from there, going into the wards, actually treating patients, figuring out what regimens worked well with patients, that was the real education where it all came together.
Wow, so you actually talked to patients who were addicted to opioids?
Yes, they came in, they talked about how they were fine beforehand, they had pain, and before they knew it, they couldn't get out of bed without their pain medication. So seeing that side and then actually going in the hospital, treating patients after major surgery, minor surgery, it really sticks with you.
So having gone through all of that, what do you believe your role is within the opioid crisis as a future orthopedic surgeon? I shouldn't say future, as an orthopedic surgeon now, because you're a doctor now.
Yes. Yeah, so education is huge. I've actually published papers on patient education and how if you increase patient education, you can really manage the expectations of your patients. Therefore, an example would be having a nice consultation before the surgery, having realistic expectations. You will experience pain directly after the surgery, and having a multimodal regimen, really. And, we don't have to go straight to opiates. We can use other things. We can use things like muscle relaxers. We can use NSAIDs or anti-inflammatory drugs. So having that conversation with your patients really goes a long way.
How has the opioid epidemic impacted your current education right now?
it has really been a large staple in my education. Working in the emergency room, you definitely hear about it. Working with post-operative patients, you hear about it. It impacts everyone. So it really has been my entire education. I don't know medicine without the opioid epidemic.
I would imagine it as a black man, seeing a lot of black men addicted to opioids. And in your training, what would you say to them if you could?
First, I look at them as any other sick patient. I don't have a stigma, and I think that's very important to start there. You want to see them as who they are, a sick patient who needs your help. So I look at them, I try to get to the root of the issue, and that really is a good basis to starting a treatment plan for them.
Explain how the opioid epidemic has changed approaches to treatment within certain populations.
Yes, so there have been a lot of studies actually in the emergency rooms of minorities, patients from underserved areas actually being under prescribed pain medications. So they come in and doctors are saying, oh, they're fine, or they give the 10 out of 10, but some doctors might not be so open to start them on pain medications. So we have two extremes here. We have high reserve, especially for the black and brown community, sometimes with prescribing them pain medications. And then we have the fear. I actually published a paper, and 3 out of 4 of our patients in our study during my research years had fear of addiction, but they were undergoing large spine surgeries. So really patient education is how we mitigate that.
You've done a lot of research. So what are the latest research and developments in pain management drugs?
So a multimodal approach is really where a lot of orthopedic surgeons are focusing, and also non-opioid regimens. A lot of patients don't require opiates, so it's very nice to see a lot of research heading that direction.
So talk about what you use other than opioids.
So other than opiates, a lot of times they have a multimodal approach that would include something like acetaminophen. It would also include something like Flexeril, muscle relaxers. A lot of times they have patches for pain relief, like a lidocaine patch, and really getting patients moving. But really, I think the key is patient education, letting them know a little pain is okay. You don't jump straight to opiates. This is gonna really depend on your patient education and taking that time with your patient.
Patient education is very, very important. You've said that over and over again. And expand a little bit more on why that is so, so important.
Yes, so I published a paper that really highlighted patient activation. And what that is a patient's baseline understanding and involvement in their care. We found that patients who were more active and had more understanding in their care had better outcomes after surgery. When we're controlling all other factors, we controlled race, we controlled socioeconomic status, and also optimizing patients. If you have a patient with a high clinical burden of depression, it might not be the best time to go have them undergo a long 10, 12 level spine surgery. You might want to optimize them, have them see their psychiatrist, and really optimize patients, set them up for success, and that's what we hope to do.
So Dr. McNeely, what age group is at greater risk of opioid addiction? And I know you did research on that too, because you are the research king.
Yeah, so in my short experience, I've seen a vast range of ages, unfortunately. Very young teenagers all the way up into individuals in their 80s and 90s. It's really an ugly pain cycle, and people with back pain typically use the most opiates. So I've seen a wide range of
So you
ages.
can't pinpoint an exact age range?
No, I cannot.
What are some of the greatest concerns surrounding opioids?
A lot of the patients express a fear of addiction. A lot of them had hesitancy for naloxone, which is actually a way to reverse any opioid overdose. And a lot of them had a low confidence in non-opioid management. So in our research, we saw that the vast majority of patients were afraid to be addicted, and they were also afraid that if they don't use opioids, are they going to be able to manage their pain after surgery?
Wow, and that's not true though, right? Because you can use other things other than opioids, right?
Exactly, yeah. So it really just takes, again, going back to patient education, letting them know, you might not have a 0 on the 0 to 10 pain scale, but a 2 is manageable, a 3 is expected, and if it climbs up, then you might want to take an opiate. But we have so many other options. Many of our patients are not even requiring opiates after a couple days of surgery.
How are you able to identify an opioid addiction?
So I think identifying opioid addiction is going to take an expert in the field. There are signs that we look for. Patients who they have a decreasing tolerance. They used to be able to go a long time without using pain medication, but now it's becoming shorter and shorter. They're relying on it. So we have a lot of questionnaires, but I would definitely have a talk with them and then refer them to the experts, the psychiatrists, to really pinpoint the diagnosis.
So you've learned a lot in medical school about opioids, and how do you think we can help other students in terms of opioids and how to prescribe them, not prescribe them, what to look for? What do you think is the key in that?
I think really finding mentors who are experts in the field. For me, I had a lot of mentors in different areas of orthopedic surgery and also at my medical school that came in and really educated me. And then nothing beats going into the clinic and actually speaking to these patients. As a medical student, you usually have more time than the attending physician. So I took those opportunities to really learn their stories and learn what got them to where they are. And I think after you accumulate a lot of experiences and you grow in knowledge, you really can help better treat your patients who might be prone to opioid addiction.
Tell me a story that sticks with you today from a patient.
Yes, so I have a patient in mind who actually had a orthopedic surgery, and it was back surgery, and it was very extensive. The patient was opioid naive, if you will, before, never experienced opiates. This patient got hooked immediately after surgery, and ever since then it's been really a fight to decrease their opiates. So I think that is one of the examples where patient education and really grabbing the patient before surgery and educating them on their options, that would have benefited that patient. But right now, I think a lot of orthopedic surgeons are very sensitive to this, and it is a point of emphasis in research. So I'm optimistic that moving forward we'll do better.
That patient now, how is that patient doing?
Chronic back pain. So chronic back pain is one of the top reasons patients will go into the emergency room, and they'll continue to try to increase opiates. So that patient, they're not doing the best as far as managing their pain, but moving forward, my hope is to prevent the problem before it becomes a problem.
So when do you refer a patient to pain management?
Actually, in my research fellowship, we actually had a prehab protocol. So before we even had our long fusion spine surgery, patients would actually speak to the anesthesiologist. We would ask questions about their support at home, because that's really important. If patients feel isolated after surgery, they're a lot more prone to pick up their opiates and take them. However, if they have a lot of support, if people are helping them transfer in and out of the car, they're a lot less likely to be dependent on their medications. So really asking the questions, and we do refer them beforehand to all of their pain specialists, and they speak to anesthesia beforehand.
Why do you think that is, though? Some people would say that, oh, okay, I don't have anybody here to support me, so I'm okay being by myself. Why do you think that? How does that tie into opioids, though?
I think human nature, a lot of our patients are very independent. They never had to depend on anyone until they had a fracture in their spine, or they had an injury or a fall. And at that point, it's hard to break those habits of independence. But what we like to do is encourage them, ask them, do you have family nearby? And if not, perhaps even place them in a rehab facility if it's a very long surgery and they're going to have a tough road to climb afterwards.
Tell me a good medical school story in terms of opioids.
A good medical school story in terms of opioids would probably be a patient who never had to take them in the first place. So having a patient undergo, let's say one of my patients with a total shoulder replacement, a patient able to go home same day, not requiring any opiates, and playing tennis 6 weeks after. They were in the immobilizer for 6 weeks, they feel their mobility back, and even though we like to encourage them to slowly increase activity, this is South Florida, so many patients get back to active lifestyle. So I think that's a perfect example of a win. We didn't require opiates, and our patients are happy about it.
Wonderful, wonderful. Medical students are out there right now. Some of them are probably going through it day to day. Oh my God, I don't know if I can finish. I don't know if this is for me, or I don't know if I'm going to pass a class. You've had a long road.
Yes.
What do you say to those students out there?
I would say to those medical students, never quit. I have one phrase that we use. My wife and I, we started a pipeline organization. We've reached thousands of students, particularly pre-meds. And we tell them, you can't lose if you refuse to quit. There are going to be tough days. Do not look for a nice, easy journey to success. You're going to be a lifelong learner. So if you're studying for the MCAT, you're going to be your life moving forward. So don't complain. Really focus on your weaknesses and find a supportive community that'll come behind you. There will be good days, and you'll just fight through the bad ones.
Dr. McNeely, thank you so much for being here. It was a pleasure to sit here and chat with you. I've learned a lot from you, and thank you for what you're doing for the community.
Thank you for having me.
I'm Sandy Collier, and we'll see you again next time. Well, thank you guys for joining us again. I'm here with Dr. Abdullah Bangura. And Doctor, congratulations on order. You just became a doctor, right?
Absolutely.
So can you tell us about your journey to becoming a doctor?
Yes. So it's been a long journey, but an exciting and rewarding one. I started off, I was first inspired during my senior year in high school. I was a football player and I suffered an injury and had something that I enjoyed doing taken away from me. And it's not until I met my physician, who happens to be an African-American woman, she helped me recover physically and mentally through that process. And that experience was just so impactful. I wanted to be in a position to be able to do the same for others. So I wanted to pay it forward. From that moment, I made it, made up my mind that I wanted to become a physician, specifically an orthopedic surgeon. So I went on to medical school, did everything that I could to, get in. And then, once I eventually got in, going through that process, it took a lot of mentorship. So networking, connecting with people who have already been successful on that path and just learning from them. I will say that that's been the biggest pearl that I've, learned about going through this process, is that it's going to take other people for you to get to your end goal. It's a long process, it's a difficult one, but with the help of others, anyone can get there. So that's been my story. And because of that, I've tried to find ways to pay it forward and be able to give back in any shape or form, like, doing events such as this one and be able to offer my knowledge on the opioid epidemic and what I've learned throughout medical school on that topic. So I'm just happy to be here and be able to share everything that I've learned with you all.
Well, we're happy that you are here with us, and congratulations again on your accomplishments. Let's talk about opioids. How has the opioid epidemic impacted your current education?
So I would say that it's hard to say, because when I started medical school, the opioid epidemic was already going on. So I feel like I don't have anything that I can truly compare it to, but I would say that medical school covers, the pharmacological properties of opioids. So we learn how it works, also known as the mechanism of action. We learn the various types of opioids, their strengths or potencies, and what they are used for. We also learn about their addiction potential and how to treat someone who overdoses on opioids. But as far as the epidemic or the severity of opioid overdose deaths, that is not a topic that is required for medical school to cover. So it varies depending on the instructor. Some instructor just follows the medical school curriculum, and when we cover opioids, some instructors take the time to just cover a little bit more about the opioid epidemic.
So, doctor, do you think opioids should be one of the required subjects in medical school?
I do. Like I mentioned previously, there are instructors that are very passionate about it, who are more interested in covering that topic. And I don't think that it is a topic that will take away from the rest of the curriculum. It will only add to the students' education, and it wouldn't take much time. So I think it's very important for all medical schools to cover that topic. In addition to that, we understand that this opioid epidemic is progressing, is getting worse. So I think being able to build awareness around that topic is one of the first few steps that we can take to ultimately help bring that progression to a halt.
Explain how important opioids are within your field of work. You do surgery, so of course people need to have pain medication.
Absolutely. So, for orthopedics specifically, there are a few things emphasized when considering opioids for patients. So the first thing is pain control. These are patients that acquire injuries that are deep down to the bone. So you could think about the level of pain that these patients are going to be experiencing. So these are injuries that require surgery. And also, so we want to control the patient's pain, make them as comfortable as possible. And at the same time, you were also thinking about patients who recently had surgery. So surgeons, if you had surgeons perform their operations and if a patient recently had a surgery, they're going to continue to be in pain throughout the recovery process until their recovery is complete. So being able to control the pain is very important. We don't want any of our patients or anyone that comes in with their injuries to continue to have to suffer and deal with that. Another thing that we emphasize is the side effects of opioids. So that's why it comes with a balance, because when we think about that side effects, one of the side effects, as we know, is the addiction potential of the opioids. Another potential side effect is constipation. And when you use opioids along with some of the medications that you use during the surgery, like the anesthesia drugs, that kind of increases the risk of constipation. So patients who become constipated can lead to further severe complications as bowel obstructions that could ultimately lead to further surgery. So there's different factors that come into play when using opioids to treat patients' pain, but it comes with a balance. And I think that we're improving with that in medicine. Even some physicians are discovering ways to treat pain without opioids, so non-opioid pain protocols. So there's many factors that's in play, but it just comes with a balance.
What do you believe your role is within the opioid crisis as a future orthopedic surgeon? Or not a future, you are a surgeon.
Absolutely. So just continue to discover ways to control the patient's pain while also lowering the risk for the opioid addiction. I think that is the ultimate goal for everyone. And I believe this can be done through research. I kind of hinted at it a little bit earlier with a previous question, but like for example, I just read an article about how the Mayo Clinic implemented a non-opioid pain protocol for patients who undergo anterior cruciate ligament reconstruction, so reconstructing the ligament within the knee joint. And I think that's a big, a huge milestone in the field of orthopedics. And I believe we can continue to have more milestones where we can control the patient's pain, allow them to be comfortable, but at the same time, reduce their risk for an addiction.
You talk about risk. What are the risks of opioids? And there are many, right?
Yes, there are many risks of opioids. Of course, overdose is definitely a risk. Respiratory depression, not being the patient having trouble breathing, ultimately death, constipation, withdrawal. So that's something that we don't typically think about with risk, but if someone becomes addicted and they haven't, had a dose, they can withdraw from drug and also experience very painful symptoms. Drowsiness, somnolence. There are many risks that comes with the use of opioids. And the way that things have been, working in medicine is just by trying to reduce the amount of dosage of the opioid that's being administered, but at the same time, balancing that with controlling the patient's pain.
What are some of the benefits of opioids?
I would say the main big benefit is ultimately the pain control, allowing patients to be comfortable throughout their, after they experience an injury, throughout their, following their surgery, throughout their hospital admission, allowing the patient to be comfortable. But at the same time, kind of things that we don't think about, but is treat withdrawals. So one of the ways that we prevent, patients from going through withdrawals is by continuing to by giving opioids. So that's a benefit of opioid, is giving kind of this sort of a long lasting lower dose opioid that can at least help the patient with their withdrawal symptoms.
Doctor, what is the most prescribed pain management medicine in your field of work?
Okay, I would say that the most prescribed pain management medication would be the most conservative. We try to treat pain from first a conservative approach before becoming more aggressive. So non-steroid anti-inflammatory drugs are the first thing that comes to mind. That's a category of drugs that can help. It does have its risk of its own if it's used for long periods of time or taken too much. But its risk, addiction potential is not one of its risk, and it has less risk than some of the stronger drugs that we use to control pain. In addition to NSAIDs, if you continue to think about as the severity of the injury becomes worse, we start thinking about other drugs such as maybe oxycodone. That's an opioid, right? And IV morphine. So as you progress from NSAIDs to oxycodone pills to IV morphine, it really depends on the severity of the pain level, and the goal is to provide the patient comfort at the least aggressive drug possible, or the least dosage possible. But like I mentioned, it comes with a balance with doing that. It varies patient by patient. Not every injury is going to get the same drug. So it's, some people have different pain level thresholds. So there's a lot of factors that come into play. But I would definitely say NSAIDs is the most common pain medication that's prescribed.
So, doctor, we have a lot of medical students who are probably watching this, and those who are probably thinking of going to medical school. What is your advice to them?
I would say first, as you go through your education, as you're going through the material, the content, I would say start thinking about how you can use some of this information to make a difference in the world. As medical students, you often put yourself in this bubble where you want to just focus on the content that's presented to you by your instructor, or the content that you're reading in the book, because ultimately your goal is just to pass the exam or do well on your boards. But if you can start thinking about how this information that you are learning can relate to what's going on in the world around you, like the opioid epidemic, I think that will translate well into the clinic. And then when you're done with your education, you will have better strategy, and you'll better be able to come up with a treatment plan for each of your patients. I believe that will ultimately help you become a better doctor.
Do you have anything else you'd like to add?
Yes, I do have a few things that I would like to add for the medical student audience. I would say that as you go through this path, just keep in mind that you're not on this path alone. You're not on this journey alone. There are many people that are around you that are willing to help. Even me, I'm one of them. And when you're ultimately going to, you're going on this journey that these people ahead of you have gone on, and it will become a lot easier for you if you, adhere to their advice or seek out that help. So networking, seeking mentors is the best advice I can give any pre-medical student or medical student. I will say that it's been a long journey for me, but I probably would not have been able to make it as far as I've made it without my mentor. So mentorship is extremely important. And I really appreciate you all for having me be able to speak on this platform. speak about what I've learned throughout medical school on the opioid education topic, and to be able to connect with you guys and be able to offer anything that I have to offer. So I really appreciate everything.
Dr. Bangura, we appreciate you even more, and students like yourself and new doctors like yourself, because we can only take care of this problem if we do it together. Thank you for
Absolutely.
joining us.
Thank you.
I'm Sandy Collier. We'll see you again next time. Well, thank you guys for joining us. Oh my goodness, it feels like we were recording that session all over again. I was just glued, just listening to everything. Dr. Smith, Dr. Neely, Dr. Bangura, thank you guys so much for spending the time with me. And you know what? We got questions already. So let's jump right in with the questions. Dr. Smith, I'm going to start with you. If you suspect that a prescriber, such as a physician or pharmacist, is using the system to overprescribe opioids, how do you go about reporting them to the right authorities?
Right, thank you. That's a great question. So the first thing you want to do is really make sure that what you're seeing is an overprescribing of that prescription. You want to double check and make sure maybe there's no prescriber and patient relationship. Maybe you're seeing a large number of prescriptions coming in for the same, diagnosis for a different amount of patients. Then what you want to do is just reach out to your local DEA office and kind of, let them know what's going on so they could take care of it and do their research.
I would imagine that with something like that, you would start thinking, oh my God, is there going to be some sort of retaliation from the patient or the prescriber if you prevent them from opioids? How would you deal with that as well?
Personally, I have never had the experience had the fear where somebody would retaliate. But what I would say is just approach the situation, be sincere. So if there's a patient in front of you and for some reason you're not going to dispense that medication, then let them know the reasons and deliver that message sincerely. At the end of the day, the patient will know that you're trying to do what's best for them. You want to make sure that their pain is managed, but you also don't want to do harm and make sure they don't overdose or become addicted to that medication. So just really approach it, treat everyone like they're your family member, and just be upfront and deliver the message.
I like that. Dr. McNeely, we got a question for you. If a patient declines the multimodal pain management approach and only desires opioids for their pain, how do you handle that situation? And do you refer them to another provider, or would you give them a low dose? What would you do? Tell us, and you're a new doctor, so I'm definitely interested to hear what would you do in that situation?
Yes, thank you very much for that question. I've had patients show a lot of hesitance. I also published a paper where 3 out of 4 patients out of a large cohort lacked confidence in a non-opioid pain regimen post-operatively. So this is a very relevant question. I start at patient education. Patient selection means that preoperatively I spoke to this patient and I gave them expectations for what they should expect post-operatively. Therefore, we're not trying to eliminate all pain. However, we will try to give you a good multimodal pain regimen. And at that point, I actually would have them agree with my plan. When I allow the patient to participate in how I expect to manage them, that's something I learned during my research years of prehab. Instead of trying to chase the problem afterward, I try to put everything on Front Street. At that point, to answer your question, if they refused, I would try to get to their fears. Why do you refuse? And I would tell them I've had many patients who are successful with our multimodal pain regimen, including lidocaine patch, including NSAIDs if there are no contraindications, or Tylenol. And then at that point, I would really kind of get to the issue. At that point, if I fail to control their pain, I would call upon a colleague who specializes in that pain management.
That sounds great. So let me ask you another question. How soon after orthopedic surgery can a patient start exercising again? And would you recommend starting sooner rather than later for joint flexibility and pain management? Let's talk about that whole scenario.
Great question. So it's very patient specific. That means at baseline, what was your mobility status? What was the nature of your injury? What intraoperatively, what did we find? Did you have a partial tear of a knee joint? Was it a complete tear? And also, were there any complications? All those things will define your ability to return to play. For instance, someone with a shoulder rotator cuff tear, their postoperative course to returning to activity will be a lot different than someone who had a large femur fracture. So it's going to be very specific to the patient. So I would encourage everyone to just speak to your surgeon and let them know your goals. That way you can participate in the plan.
Dr. Bangura, I've got a question for you. Who do you believe should bear the responsibility for teaching the opioid epidemic in professional schools?
Sandy, I don't think Dr. Bangura is on today.
Well, you know what? So, you know what, Dr. McNeely, I'm going to let you take that question because you are a newly doctor, okay? And so I'm going to let you take that question. And Dr. Smith, you can jump in after he's done with your comment as well if you have anything to add. So go ahead, Dr. McNeely.
Thank you, Dr. Collier. I believe everyone should actually bear the responsibility. We're taught to engage in lifelong learning. That means it's not my teacher's responsibility to teach me everything. Some things I'm going to observe on the wards. Some things I'm going to ask or delve into myself. Some things I'll conduct research to learn from my patients. So I believe everyone who engages in medical care of any kind should actually put the onus on themselves to better understand the struggles of their patients and also how to better treat them.
And Dr. Smith, do you have anything to add to that?
No, I think Dr. McNeely answered that, spot on. Really just got to continue doing your education, work together as a team, and it's up to you to really educate yourself. You could do it through practice, or you could do it through, reading and researching as well.
And Dr. McNeely, seeing that you just got out of medical school again, do you think it should be written in the school curriculum? What do you think?
Yes, and that's actually been my experience. We learned about opioids and the crisis, and we talk about current events quite regularly. We learn with a table-like setting, a problem-based learning. So we would have a patient who has had a chronic use or dependence of opiates, and then we kind of delve into that. So I believe that's kind of where the trend of medical education is, and I'm excited about it because it's very pertinent to where we are now.
And I know we talked about this a lot, and Dr. Smith, you can jump in here as well. Mentors. How important are mentors in terms of dealing with this opioid epidemic and any kind of epidemic that we would be going through in life? How important is mentors?
I think mentors are extremely important. You need mentors to kind of guide you through your path, especially when you're starting off as a new practitioner. If you have somebody to reach out to and, give them a case study or a scenario that's going on, and you kind of pick their brain about it and learn a little bit from them and kind of go from there when you get your answer.
Dr. McNeely?
I would certainly agree. The first thing I would do as a new physician is call Dr. Smith and say, hey, Dr. Smith, what would you just suggest? I rack my brain, and I speak to my pharmacy colleagues quite often on the phone. I also have different surgeons that treat everything differently. So I ask them, what's your thought behind that? And it really just gives me more tools on my tool belt to be able to treat patients on my own moving forward.
And I'm going to throw this question out to both of you because I think this is a really, really important question. Do you guys foresee a future where opioids could become obsolete in pain management after surgery or after any kind of trauma? And I'm going to let you start, Dr. Smith, by answering that one.
I would say no. Opioids, they have their place. They are there to treat pain. And in certain cases, there is a need for opioids. So I would answer and say no.
Dr. McNeely?
Yes, I would agree with Dr. Smith. One of the primary reasons we have opioids, and we actually have sliding scales of IV opiates for breakthrough pain. There were a lot of studies actually very pertinent to this conversation where particularly Black and Brown patients will enter the emergency room and they would be actually under prescribed pain medications because practitioners did not either believe them or they thought they were drug seeking. So I think there is a place for them. However, with patient education and webinars like this where we can educate our patients, I think that we can use them where they're used best and we won't be so reliant on them long term.
Well, talking about webinars like this, guys, I want to thank you guys for joining us tonight. I thank you for the time that we spent together. Dr. McNeely, I'm happy about you and Dr. Bangura just graduating from medical school. My son is studying now to be a doctor, and I told him I cannot wait until the day comes that I can walk in the hospital and say, "Is it Dr. Collier here? That's my son. Is Dr. Collier here?" He says, "Mom, I know you will do that." And I'm like, "Yes, I would." So you guys are doing great for the community. And talking about next time, we are going to have another series on opioids. So we're really looking forward to that. For those of you who are on here right now, there's a free CME QR code at the end. And also one lucky person is going to get a $50 gift certificate for being here. For anybody who wants more information on opioids, and this is so important, and because I know we all know somebody who may be affected by opioids, please log on to opioidpreventionpbc.com. That's opioidpreventionpbc.com. And I want to personally thank all of you. And I want to thank Sadia. I want to thank Laurel. A lot of people just see the final product of these series that we do, but there's a lot of work that goes on behind the scenes. Laurel, Sadia, Ron from Dreamlight Media. I can't do this by myself. I have a whole team, and I want to thank everybody. And all of you who are joining us, who constantly join us on this, thank you so much as we continue to share this message so we can make a difference in our community. I'm Sandy Collier. We'll see you again next time.
On behalf of our organization, we would like to thank you for taking this opportunity to learn. We would also like to thank our dedicated team and panelists for playing a vital role in making this series possible. Again, if you'd like more information on T. Lee Ward Jefferson Medical Society, please log on to our website at tljmedicalsociety.org. Thank you again. Have a good night.